So I'd like to segue into something that's a corollary to what Neil just had a great talk on. And so what we're doing effectively is we're trying to minimize in terms of the level of invasiveness things that we do. Big stuff on the inside, little access stuff on the outside. You can sit in a big room and talk to one of our spine surgeon colleagues attending here today, doing a fellowship, and talk a little bit about large spine surgery. You can sit in a big room, 25, 30 people, and you can say, you know, 50 years from now, we're not going to be making incisions like this for a T10 to the ALM. 50 years from now, we're going to be doing things through small little access points, small little poke holes. The days of big open surgery are gone, or they will be gone. And everybody does what you guys are doing. It's kind of like this. It's natural progression, natural advancement. The only two questions that we have to answer is when are we going to start and how are we going to get there as quickly as we possibly can. So the barriers to minifying the approaches, what we do, there are various and sundry barriers, and these are things that Dr. Naidu made a comment that they don't teach things like reimbursement, coding, and billing. They also don't teach things like how to develop Category 1 codes for CPTs. They don't teach you how to do an ICD-9 to ICD-10 transition or develop those codes. The credentialing is something you don't ever hear about until you apply for credentials. The first time I applied for credentials, I'm like, what? Why? You know, I do this. I can't do this at this hospital. And, you know, I remember the first time we talked about surgeon, non-surgeon. So I'm an interventional radiologist. I've been around peg in a square hole for my entire career, and I focus really on the spine. So when my surgeons have a bleeder, they call me. When they have the epidural abscess or hematoma, call me first. And I call them for other things. It makes for a great collaboration. But I remember the first time I got into a credentialing issue, it was the anesthesiologist didn't want me to do vertebral augmentation. That was their turf. They didn't want me to do epidural steroid injections. And I talking to my colleague about this, interventional neuroradiologist, and he said the same thing happened to him. So apparently you could put a catheter in somebody's brain to save their life from a stroke, but you can't do a lumbar epidural injection. And so we have to understand where these boundaries are. And so the credentialing committee is something we'll talk about. We'll talk about malpractice coverage. People don't address this at all. If you do an interspinous decompression fusion spacer, are you covered for it? Do you know you're covered for it? Maybe that's a question that a lot of us should answer and at least know. That's why we're going to bring that up. I talked about Category 1 to Category 3 coding and then procedural refinement as to what this is. So credentialing is a verification of your training and experience. The problem with new minimally invasive devices and techniques is these are all new. They're brand new. So how do you tell somebody's competence when there's maybe a handful of people in the world that are doing these things? How do you define somebody's competence whenever they're taking the techniques from Europe to the United States or vice versa? How do you verify somebody's competence? Because I mentioned that I'm a different specialty than Dr. David, Dr. Naidu, Dr. Shauna. We're all different specialties, but seemingly look the same, right? Do stuff with the spine, and we demonstrate techniques. And if we didn't tell you we're different specialties, you may never know. But there's at least 7 different specialties that do interventional pain. My fellow is here, Dr. Phillips in back. He is not a radiologist. He's family practice. I've trained anesthesia, trained physiatry, family practice, interventional radiology, orthopedic surgery, and they all have various. So how do you judge competence whenever there's a lot of different heterogeneity? It makes this difficult. So the credentialing procedure is about determination, and you base that determination on specialty. You base it on things like training courses, industry-sponsored training courses, Seattle Science Foundation courses that you do on the weekend, spending hopefully well-spent time to do this. proctorship, documentation. You have people submitting letters for you that go through a procedure code, list that. They go through a sample dictation, a sample op note. They go through maybe your experience being proctored, taking courses, and an expert opinion that is written on your behalf saying, yes, I support Dr. David in doing this because he is extremely well trained. He is precisely the type of individual that should be doing this, submitting this to the Credentials Committee. And these are the type of things that you go through credentialing to have. So this, anybody know what this device is called? Let's call a Minuteman. So this is an interspinous fusion spacer. You could put this in. This is coded as a 22612 to 22840, and I'll go over what that means in a second. So these are put through an incision that's 2.5 centimeters done from the side, and it's done in about half an hour, roughly. So these are pretty easy to place, very effective, and there's reasonable data behind this. This is a fusion code. So as an interventionalist, are you covered to do this? Well, it depends. So I've had probably 5 different malpractice insurances in my career. And you switch for various reasons. You switch to do various different cases. And if you're not covered, and the only way to know is to call your insurance company. Said, here's what I want to do. Here's the name of the device. Here's the CPT code. Am I covered to do this? And if you're covered, that's fine. But if you're not, you may need an insurance rider. Some people call this an insurance endorsement. So this is an add-on to make sure if you have something go wrong and you're sued, that you have adequate coverage for this. So each specific new thing that comes down the pike, you'll need to check to make sure if there's any lack of clarity, if it doesn't cleanly fit into one of these categories. Speaking of category, we talked about reimbursement. And next to oxygen, reimbursement is a close second, right, in terms of importance. So you have to have the idea of what you're doing is getting reimbursed, and you have to, what really works is to understand where these codes come from. I mentioned Category 3 codes. Category 3 codes are applied and they're developed to Category 1 code over about 2 to 5 years. And you develop this, and I'll talk a little bit more about that process. A recent example is basivertebral nerve ablation, right? 6482829. New code development. I've heard people say something like, oh, we don't develop new codes. I mean, what? Aren't you paying attention? Here's one that just came down the pike. Not only that, it has a new ICD-10 code, vertebrogenic back pain. It's 54.51. I remember being on a conference call with ICD-10 people and saying, well, you know, it seems like we should have a code for discogenic back pain because this is the most common cause of back pain worldwide. And everybody's like, yeah, sure. So what is it? Do we code for lumbago? I mean, this sounds like, you know, an anachronistic term. And so I find it interesting that to the chairman of the committee, that we don't have an ICD-10 code for the most common cause of back pain worldwide. Think about that. So this is changing all the time, hopefully, and hopefully will continue to change. In order to have a Category 1 code, you need 5 levels of evidence, or 2 levels of evidence with more strict criteria, meaning heterogeneity of authors and subject matter, with at least 2A evidence. 2A evidence is a cohort study or cohort matched trials. So preferably 5 forms of evidence, and including 1 level 1 trial, a pivotal trial, followed by just a cornucopia of different types of trials to make 5 trials total. So CPT codes are developed like this. The Category 3 code is called a transitional code. You've probably heard this referred to as a T code. That's why they're called T codes, because they're transitional codes designed to transition from a Category 3 to a Category 1 code. A Category 3 is assigned, it's assigned an APC, an ambulatory payment classification Category 1 through 6, and you get the reimbursement. There is no global fee. There are no separation between physician fee and technical fee. These two together are referred to as the global fee. For a Category 3 reimbursement, you're assigned an APC category. That's the amount that comes to you. There is no physician fee. So if you're performing let's say you're performing a new Category 3 code of a device in the hospital, and it takes you an hour, hour and a half of your time, and there's no physician code, no physician fee associated with it. That seems like that's important, right? Note to self, may get paid nothing for this case. So that needs to be worked out with the facility first. And all these go into developing RVUs, and the RVUs across the top, work, practice, malpractice goes into the total RVU multiplied by the Medicare conversion factor, and that's your payment right there. It's simple math. And the RVUs are calculated from the work. So here's an example. In addition to basivertebral nerve ablation, this is Viadisc. And so this is applied, has been awarded a T code, the T code for Viadisc, 062728 for fluoro, and 29 and 30 for CT guidance. This is a Category 3 code. And as we go through this, it will be assigned, has been assigned, a level 5 code. This is just an example that's going on right now, and this is here and now, and people are using it. And this is undergoing an additional phase 3 trial. And this is assigned a category level 5 code, ambulatory payment classification level 5. So it's the same as posterolateral arthrodesis of the spine, spine fusion is better said, or a total knee replacement. These are the same APC categories. And so the RVUs will be determined by crosswalking at what's a similar procedure, maybe vertebral augmentation. This is an intradiscal augmentation. And then combined with op notes and imaging. So if you think that the imaging is unimportant, the reports are unimportant, your op note is unimportant, it is very important. And it's used by the MACs, the Medicare administrative contractors, to determine the value that goes into paying for that procedure. And then once that's done, the Medicare folks will use that value to come up with the payment amount. The private insurances will use the Medicare payment amount and typically modify it by multiplying it 1.2, 1.3 times Medicare. That's the private insurance payment. So all of this is interesting. And so as we move forward to this, it will be assigned a global period, the time where you are covered under that, and additional reimbursement will not be provided. That's the endpoint. Insurance companies will be developed, coverage will be developed. For Viadisc, we'll probably get, as mentioned, a new ICD-10 code for discogenic back pain. Prior auths still account. There's no difference in prior authorizations. And people can and should use their health savings account. This is tax-free dollars that you can use provided you save for it. Minuteman, as mentioned previously, you have to mine the code. 22612, 22840. This is arthrodesis, posterior posterolateral, and posterior non-segmental instrumentation. These are the codes. So knowing that and knowing what is meant by these codes, here's a code opinion. So 22612, direct visualization. If you're not doing that, you should do it. You're not minding the code. And 22840 is decompression. So viz and decompression. And if you're not seeing it and you're not decompressing it, you probably ought not be coding for that. That's what I mean by minding the code, making sure. And the codes are done in a way that comes from tradition in the past and goes into the future, probably past its usefulness. But nevertheless, we have to mind the codes if you're doing billing and coding to make sure that you're coding correctly. Code for comorbidities. The DRG system of the hospital is different than the CPT coding. So let me ask you a question. As I demonstrate, so MCC is major comorbid conditions. Think of it as comorbidities. Does it make a difference on how much you get paid in your facility? A, 1 level, 2 levels, or 3 levels of fusion? Or B, with or without major comorbidities? Yes. That's how big of a difference it makes. This is from our friend Pierce Nunley's paper. He works out of a physician-owned place in Louisiana. We work out of a physician-owned place in Oklahoma. And coding for comorbidities has a greater impact on the reimbursement for the facility than the number of levels of fusion that you do. big time. So if you're not coding for comorbidities, major comorbid conditions, please start, because this makes a very big difference on the reimbursement that you're receiving. Major comorbid patients, it seems like everybody that we operate on is an ASA 3, right? It seems like that. And it is like that some days. But code for this. It's such a well-defined patient population that insurance companies, including Medicare, have more allowables for this. The first spacer I showed you is the same one as on the bottom. It's a fusion spacer. There's a fusion mass through the internal part of that spacer. The upper one is one of mine with spinous process augmentation. This is a non-fusion spacer. So if you do non-fusion spacers, this is 22867, right? 868, 6970. The 69 and 70 codes are going to be the ones that you use primarily. If you use a fusion spacer or anything that requires fusion, make sure and dictate in that note what fusion you're using, whether it's autograft, allograft, if it's an allograft, what it is, because you get paid for that. Put the hardware in the dictation. Medicare is not going to pay you for the hardware, and you will be using an unlisted code for hardware, but some insurances, few private insurances, will reimburse you for the hardware. So be sure to put that in the dictation. It's important whether this is Medicare or non-Medicare. Shifting gears again, endoscopic discectomy. The 62380 was adopted in 2017. This was originally started as endoscopic assisted discectomy, and I'll resist the urge to editorialize, but the bottom line is this is new, developed in 2017, and used this code, 62380. The percutaneous code, the 62287, is not really recognized anymore, so if you're using that code, I would encourage you to reevaluate. And then some of the work comp is using the annuloplasty code and combined with the perc disc code. So the only time the 62287 is being used is in some work comp jurisdictions combined with an annuloplasty code. Just note to self. Coding for SI fusion, we went over this. 27279 and 80. This is one of my cases, and I took a picture of the incision because it is small, just like we described previously. This is an open case, right? Top one, minimally invasive, 27279, that's an open case. That gets an 80. And that is, and the coding is listed here, open SI joint, including bone graft with instrumentation. The closed is percutaneous or minimally invasive. That's the nomenclature coming from the code. So not only do we do mainly minimally invasive in SI joint fusions now, because in terms of operative parameter, blood loss, hospital days, et cetera, much better for minimally invasive. They also get better outcomes. So this is really a sea change. This is a paradigm shift over time. And you can get paid for, and you select patients based on this. This is NAS coding criteria, 3 of 6 physical examination findings, typical presentation of the pain at Fortin site, and imaging findings that exclude other things, and injection test, 75% relief of pain or more. That's it. That's a lot of words, but that's what you're looking for. And as I say that, you're thinking, yeah, that makes perfect sense because that's how I select my patients anyway. So, you know, credentialing is one of the important things. This is going to be really new and upfront and in your face because there'll be a lot of specialties trying to do new things with very little evidence in terms of the competence or the device evidence. Make sure the new devices that you use and the techniques that you employ are covered by your malpractice insurance. It's worth a call. If you haven't called them recently, maybe think about doing that to make sure the coverage is adequate. Understanding how we get from Category 3 to Category 1 code in terms of coding, CPT coding, will also help you in terms of your ability to get reimbursed, your understanding of what it is to mine the code, your understanding of what it is that captures the essence of the procedure that you're doing. So know what they are, the CPT codes, and what's required to meet that code. So paying attention to documentation will help you. Documentation is used all the time, including developing Category 1 codes, and in terms of Medicare figuring out how much they're going to pay you for this. Remember the new endoscopy code and the code for MIS fusion. It's important as we employ that all the time these days. So, credentialing, insurance, coding, documentation, malpractice coverage. All of these are very important as we try to minify what we do in terms of the area of incision. We'll continue to be doing big stuff on the inside, hopefully small amount of invasion on the outside, mainly dilation rather than incisions, and as we migrate from converting what we do now to a more minimally invasive thing, we have to make sure and mind all of the details to make sure we are able to bring these minimally invasive solutions for our patients. Simple example, the case that I showed you with the bilateral SI screws. That was a case I did about 3 weeks ago. She came in the morning, she left in the afternoon. A little sore, not too bad. That picture of the open SI fusion, if you could do a minimally invasive SI fusion and an open fusion, would you ever choose the open fusion? Not unless there's a barrier to the MIS, because better operative parameters and, most importantly, better outcomes. And so as we take these minimally invasive procedures that we want to do, we want to take them and present them to our patient as something that, yes, these are better in terms of your ability to recover from the surgery, the procedure. They also provide better outcomes. And they're, most of the time, as Dr. Shaw and I presented, not only are they better, they're cheaper. So these are things as we have to mind the details as we make these available to our patients to make sure, to ensure that these new procedures with better pain function, quality of life outcomes, and less invasiveness are made available to them. Thank you.
Awesome.
Thank you. So, questions, comments?
I'm glad you did a potpourri of procedures because that sends a message that innovation is right in front of you, but it's also behind you, it's around you on both sides. But the principles of how to do innovation safely, efficaciously, with the value equation always kept front and center because you're providing value for your patient. So it's really spectacular. Good job.
Thank you. Thank you very much. Yes, Brian.
Hey, Doug, and really Neil too, really, because it kind of, that last talk really kind of pigeonholes really into this question. So, you know, when you're looking at credentialing specifically, you know, especially for non-surgical trained physicians, a lot of the credentialing bodies will be real specific about, you know, ACGME approved training in that specialty. But if you look at somebody like a neurosurgeon, some of the procedures that spine surgeons learn how to do, they didn't learn how to do in training. So the way I think to get around that, or maybe we can discuss it, or maybe we can both discuss it, is how do you get around that? You know, you say, well, because everything that we're talking about today, including this course, which was the purpose of really putting this course on, was to try to create that. How does orthospine and how does neurospine get around that from a standpoint of they learn this outside of training, so they want to do that procedure?
So let me answer that by giving everybody is my colleague, my peer, and above a word of caution. I hear a lot of people say ACGME accredited fellowship. So, you know, I was on the ACGME in the 90s, and I was a resident representative. And the way that this works is people have specialties and they have subspecialties, and the subspecialties, whenever I was a resident fellow, are very different than they are now. How much do I do now that I learned in training? 95% of everything I do now, I wasn't exposed to in training. Listen, I'd be practicing medicine from 1993 if I didn't learn anything new, right? Is that what we really want? Or do we really want continuous education based on training and experience? So the people who say, well, I'm an ACGME certified fellow, so new specialties come along, and then their fellowship, non-ACGME certified until they're very well established. Then they become certified, and then the natural evolution of this is often they go away. They become over supervised and go away. So to do that excludes the vast majority of people, and to pay attention to ACGME accredited fellowships ensures that we never advance at all. Because the only people that will be allowed to do that are people that come through a very narrow specialty window, very narrow specialty applications that is under a microscope in terms of ACGME accreditation. We'll never have anything new. We will never have other people do this. We'll never have other specialties do this. And we've excluded the best and the brightest from the development of new techniques. So this is a message to my peers. Be a little bit more open. Do something that's not so easy. You have to evaluate somebody's native ability and their education, training, and experience to do this procedure, rather than to do a hand wave and say because you're not board certified with an ACGME accredited fellowship, you shouldn't be allowed to do this. That's blanket application, and I don't agree with that at all. The reason why people tend to do that is because it's easy and it's a turf war that protects their territory. So I didn't go through an ACGME accredited fellowship. Why? There was no such thing at the time. I'm fellowship trained and did my fellowship at a big hospital in a small city in Rochester, Minnesota, but there was no such thing as accreditation back then. So we have to be careful, otherwise we'll squelch new product development and innovation. And we need to focus on the factors that go into credentialing, not just board certification. Ronald.
Yeah, just to add to that comment, it's such a great question. We actually, with the American Society of Pain and Neuroscience, wrote an article on credentialing for these novel minimally invasive therapies. And as Neil pointed out, when you write these publications and you have different disciplines, so we had neurosurgeons, orthopedic spine surgeons, anesthesia pain, PM&R, neurology, I don't think any of the mental health services, but we had basically everybody on this paper. And the reason I took the lead authorship of this paper was because when I went to my hospital, the neurosurgeon said, "You're doing a sacroiliac joint fusion procedure?" And that really kind of bothered him. And so it became a huge deal to the Health Technology Assessment Committee, the Value Add Committee, however you want to put it, whatever acronym you use. And so I said, well, let's describe how we credential physicians in our country, and this applies to anyone internationally as well. Let's discuss how we educate physicians on these therapies and ensure that they're doing it in a safe and effective manner. And so if you have a chance, it's in Journal of Pain Research. It's a really comprehensive article about all the ways we do that. And it really goes back to our training. So, surgeons have historically done apprenticeship models, right? So the surgeons learn from other surgeons. They're side by side, scrubbing in. And then when they do their boards, right, they have to review their cases and go through complications. And then as anesthesiologists, we have a certain way of doing things, sort of maybe not as apprenticeship model, and we get thrown into the fire. Interventional radiology, you have your own ways. So we come from these various ways of learning, but we all add to how we do these procedures. And frankly, as I sit back and look, you don't want to point any fingers and say, you're not ACGME, you're not a surgeon, because that only harms us. I mean, I don't want to say anyone can do anything, but as long as you're trained the right way, you learn the right way, you understand the process, and there is some sort of way to get there, we can do these things effectively. So I encourage you to check that out, and hopefully it helps us standardize going forward. But I agree with you. We're really in an interesting, gray, important area of medicine that's going to help our patients in the future. So I encourage you to check that out. It was a great question.
I'm going to mirror what Doug said and what Ramos said. I don't do what I was trained to do. I employ modified techniques that have those core principles embedded in them, but they're done in a novel, more efficient, less invasive manner. My practice continually evolves with my education. That's the part that's thrilling. But I do also sit on the other side of the fence. Last night, had to sit down and make calculations with others. How do we cover the because we're a self-insured, we have our own medical malpractice with Lloyd's of London as our secondary. How do we cover this? Because we as an organization, all 200 of us, If something goes south for any of our physicians, we are on the hook. And that focuses you like a laser. And you start asking, okay, what additional cost burden is this going to be distributed across, or is this going to be practitioner-based? So there are practical aspects to the business of medicine. But the most important thing is as we evolve and move forward, it's the generosity and the joyful collaboration, not the barriers of turf. You know, don't build a wall around yourself. You'll only find yourself within a prison. And similarly, you can't shake anybody's hand across a wall. So doing the things that are being espoused here, participating in data-driven efforts that show equal capability across different practice will allow the folks who are working on the credentialing side to have ammunition to say, wow, you know, these innovative techniques are being safely done by a lot of different people. So participate in that, because it's impactful and it's your future.
Okay, so now I think we will break for the BioSkills lab.